All right, so we'll get started. Welcome everyone back to UCSF's Cardiology Grand Rounds. I'm honored to present today Dr. Jonathan Tobis, who will be speaking to us on PFOs. Dr. Tobis is a native of New York, but moved to California for his medical training, and he's remained here ever since. He completed his residency and cardiology fellowship at UC Irvine, and subsequently remained there on faculty for over 20 years. In the mid-1990s, he was recruited to UCLA as a professor of medicine and cardiology, and has had multiple leadership positions there, including Director of Interventional Cardiology and his current role as Director of Interventional Cardiology Research. His original contributions to cardiology include the development of digital angiography in the 1980s and the development of one of the first intravascular ultrasound devices, which helped explore the mechanisms of coronary angioplasty. For the past 20 years, his research has been in the management of patent foramen ovale, which is what we're going to hear more about today. And so if anyone has questions over the course of the talk, please raise your hand or, as usual, type them into the chat box. Or if you prefer to keep the questions anonymous, you can just direct message me. And with that, welcome, Dr. Tobis. Excited to hear your talk.
Thank you very much, Leila. I'm pretty excited about patent foramen ovale. We were talking about how I got involved in this. It was a lecture from Jim Locke in the 1990s. And I was sort of fascinated by the concept that here was this anatomic structure that we knew about for many years, but never had the connection with all of these multiple possible associations. And the more we've learned about it, the more things that can be associated with it. So I hope you'll enjoy the variety of conditions that can be connected with this and learn something about it. Wait, how come I'm not? There we go. So the clinical problem, I'm not sure that I can see my slides completely because the video is lined up on the right side. I can't seem to change that. Anyway, the question is a stroke occurring in young people, and how can a blood clot from a presumed venous structure get across the heart and bypass the lungs and wind up in the brain, so-called paradoxical embolism. And so, as I said, it was really only in the 1990s when we started doing echoes much more frequently and agitated saline bubble studies to look for right to left shunts that we identified that there were these people with patent foramen ovale and that there was a higher frequency of this condition in multiple clinical scenarios. So that we were no longer dependent just on autopsy for making this diagnosis. So let's go back to embryology of why we have a patent foramen ovale anyway. In the infant, in utero, the baby's not breathing any oxygen from the lungs, so the oxygen comes from the placenta and travels up the inferior vena cava. If it went the usual way through the right heart to the lungs, the oxygen saturation in the placental blood is pretty low to begin with, only about 67%. So it would continue to lose oxygen, and presumably there wouldn't be enough oxygen for the baby's brain to mature or organs to develop. So this mechanism permits the oxygenated blood from the placenta to get across the atrial septum directly to the left heart and to the baby's organs. And it is so important that this is preserved throughout evolution. All mammals have patent foramen ovale. Once we're born, the pressures change, the flap of the PFO closes, and it's sealed shut. But 20% of people, it doesn't close. We think this is genetically determined, and that's one of the projects I've been working on. But in those 20% of all humanity that we think walking around with a PFO, It doesn't usually cause a problem throughout life, but we estimate about 1 in 1,000 people per year who have a PFO wind up with a stroke. This anatomically, this is what the septum looks like. You have a septum secundum, which is thicker than the septum primum, and the fossa ovalis is the sort of portion of the septum, but this is a closed septum. The conditions that have been associated with patent foramen ovale just seem to keep growing. There's cryptogenic stroke, which we'll talk about, migraine, headaches, orthodeoxia, platypnea, we'll discuss briefly. You can have emboli to the not only to the brain, but to the heart, and have an acute MI with normal coronaries, decompression illness, high altitude pulmonary edema, and acute mountain sickness, obstructive sleep apnea, coronary or peripheral spasm, and I'll show you a case of that. There can be brain abscess just from the right to left shunt. And then there are some reports of epilepsy of unknown cause having a higher frequency of PFO or syncope of unknown cause. And the unifying hypothesis is that some material, either thrombus, platelets, nitrogen bubbles, low oxygen bacteria, or other chemicals, bypass the lungs and enters the arterial circulation through the PFO. So this is what it looks like. I'm sure you're all familiar with the transesophageal echo with an atrial septal aneurysm blowing out of the atrial septum over here. And the PFO, as seen on this agitated saline study, is mostly a tunnel rather than an ASD where there's a separation between the septum primum and septum secundum. And the association has been that 60% of people with a cryptogenic stroke have a patent foramen ovale. But if you look at those people with a cryptogenic stroke and have migraine and frequent aura, 93% of them have a PFO. Occasionally, you'll see a thrombus straddling the atrial septum as seen over here, or an autopsy over here. This is rare, and this is the only condition in which you can say, or the neurologist would say absolutely that that stroke was due to a thrombus and a paradoxical embolism. Most of the time, the strokes are the emboli are very small, 1 to 3 millimeters, which is enough to occlude the cerebral vessels. And so a PFO associated stroke is usually a diagnosis of exclusion. You don't see the thrombus per se. The workup for a PFO, I assume most of you are familiar with this. You want to exclude atherosclerosis of the cerebral vessels, exclude atrial fibrillation. I often get an MRI, even if they haven't had a stroke, if there's some other reason they come in, such as migraines, because you can have clinically silent strokes. The best way to assess for a right to left shunt is a transcranial Doppler. It's the most sensitive method, and I'll show you a picture of that later. We have the patient blow into a manometer at maintain 40 millimeters of mercury, and that way you know that they're actually obtaining that pressure rather than just sort of pursing their lips. I also draw back blood in the saline injection that emulsifies the blood, the bubbles, and so you get a more of a foam, and the bubbles stay in solution. TCD is also more accurate than echo because what you're imaging through the temporal bones is the middle cerebral arteries. You're getting the entire volume of the artery, whereas an echo is just a tomographic cut of the left atrium, and you may not see the bubbles that are going across. We usually get a transesophageal echo to make sure there's nothing else going on, such as an ASD, sinus venosus defect, and to determine if there's a septal aneurysm. You want to exclude atrial fibrillation. We usually get a 2-week ECG monitor, and then hypercoagulable labs and determine whether they've been on estrogen. A lot of the women who come in with young women with stroke have been on birth control pills. One of my pet peeves is the literature on PFO is often based on echocardiography, and a transthoracic echo is misleading because if only a few bubbles go across, they say it's a small PFO, but this is not very accurate compared to a transcranial Doppler. Also, they'll say on the echo report, the bubbles come in late. That means that it's going through the lungs and not through PFO. And that's completely false. It just depends when the bubbles go up to the superior aspect of the atrial septum so that they can then go across the PFO. So late bubbles do not mean transpulmonary. It's usually a PFO. TE often get the report that this was a small PFO based on TE. We've done a study comparing measuring PFO size at the time of heart cath with balloon sizing versus TE or ICE, and TE completely underestimates the degree or the size of the PFO. So TE is useful for identifying atrial septal aneurysm, but doesn't tell you the degree of shunt or the size of the PFO. And especially when the neurologist will say, well, this is too small a PFO to have caused a stroke. That is incorrect. The average PFO is 7 millimeters in diameter, and most of the emboli are 1 to 3 millimeters. So it's adequate to cause that stroke. The other thing is that in over 2,000 transcranial Dopplers that we've done in my lab, a right to left shunt is due to a PFO in 99% of them. Only 1% was due to a pulmonary arteriovenous malformation. If the patient has hereditary hemorrhagic telangiectasia, then that's different. They have commonly pulmonary AVMs. But if you don't have a patient with HHT, then 99% of shunts are due to PFOs. So don't chase down PAVMs. It's unlikely. The gold standard for a PFO is not an echo. It is a right heart catheterization with the ability to pass a guide wire across the atrial septum. And I think a lot of the literature has been misleading because they based their diagnosis on echoes, and you miscategorize a fair percent of the patient population by saying they don't have a PFO when they actually do, or vice versa. And even TEE is at least 10% incorrect characterization, where they'll say there's no PFO because they don't see bubbles going across. Transthoracic echo is even worse, 50% false negative. So when we're working up the PFOs, my preference is to get a transcranial Doppler first as the best screening test, and then get a transesophageal echo to actually look at the anatomy. The echo lab told us we're going to stop doing transthoracic echoes to work up PFO because it would come back negative, and then they would order a TEE anyway. So this is how we close a PFO. Here's the flap. It opens up just with a guide wire. There's the catheter. And then inside the catheter is this device, which is made out of nitinol wires that forms a spring that forms a disc on the left atrial side, a disc on the right atrial side. The white material is Teflon. It's Gore-Tex. This is the cardioform device. There's a little locking mechanism. And then scar tissue grows up over the next several months. This is a permanent implant. It takes about this long to actually deploy the device. The patient's in the cath lab for 2 hours, but most of that's set up and breakdown time. The actual procedure is 15 minutes. And it's an outpatient procedure. They go home the same day if you use intracardiac echo. The smaller PFOs are harder to cross. So here's a J guide wire riding up against the septum. This is intracardiac echo. So the right atrium is up here and the left atrium is down here. This patient had a positive shunt, had a PFO, but the J-wire diameter is wider than some of the PFOs. So if you can't cross with a J-wire, you either use a straight wire, or I just use a multi-purpose catheter and cross it with the catheter itself. Then you can measure the size of the PFO. This is an REO view. So you're measuring the width of the PFO in this view, right atrium superimposed on left atrium. And this is the LAO view. This is right atrium. Here's the left atrium. Here's the PFO. So this is the height, the true height of the PFO, the true width. Then you get occasional septums that are non-compliant. This is sort of described as a gooseneck deformity to the atrial septum. But I've never had a problem with the current PFO devices to close a PFO, no matter what the formation or the size, or whether there's an atrial septal aneurysm or not. In the early days, people had trouble getting across, they would do a transseptal puncture, but that's really unheard of nowadays. This is what it looks like. Here's the intracardiac echo. This is the cardioform device. This is the left atrium. This is the right atrial disc. This is the plane of the PFO. And then by intracardiac echo, here you have the intraatrial septum across here. Septum secundum is thicker, septum prime is thinner. The left atrial disc on the left atrial side, the right atrial disc on the right atrial side. You basically, like Pac-Man, you sandwich the atrial septum and then release the device to close it. There have been multiple randomized clinical trials showing that closure is preferable to medical therapy, so I won't go into those. I think it's pretty generally accepted that PFO closure is the right thing to do if you make a diagnosis of cryptogenic stroke due to a PFO. And we'll talk a little about the neurology perspective on this. So just some learning points. I consider PFO as the most common congenital heart defect because 20% of people have this. And I think it is a defect since it can lead to migraines and stroke and other conditions. But we did a study of, I think it was like 55 families. And if you look at first-degree relatives, 63% of first-degree relatives of people with a PFO also have a PFO. So it's clearly genetically distributed. And we're trying to find out what those specific genes are. I mentioned this 1 in 1,000 incidents of stroke. But after the first stroke, the rate of recurrent stroke on medical therapy is 1% per year. So over 10 years, the clinical trials showed that it was a 10% incidence of recurrent stroke in 10 years. We don't know further out than that because the trials didn't go further than that, but the extrapolation is that it will continue at 1% per year indefinitely. And clearly, I've seen people who had a stroke 30 years ago. They didn't know what the diagnosis was. 15 years ago, they had a second stroke. Then they come in with their third stroke. Finally, an echo is done, a PFO diagnosis is made. But those other strokes were clearly paradoxical emboli as well in a patient with a PFO, even though now he comes in at age 75 with his third stroke. So now the randomized clinical trials have demonstrated that PFO closure is preferable. And I think I described this before. The frequency of PFO is 60% in people with cryptogenic stroke. But if you have a history of migraine with aura and cryptogenic stroke, then the frequency is 93%. So this is a useful way when you're getting a history of a patient. If they have migraine with aura, it's better than a 50-50 chance that they're going to have a PFO. And so then you can think of what associated conditions they might have, which could be associated with the PFO. And then PFO associated stroke is associated with thrombophilia, venous stasis, straining, and birth control pills. 50% of the women that I see with stroke had been on some form of birth control. This is how we do the transcranial testing. The ultrasound probe is up here. Are you guys doing transcranial Doppler, Leila?
Not routinely for the diagnosis of PFO, though I'm sure it's something we can order.
Okay.
Typically, we follow that, TTE and if needed, TEE approach.
Because a lot of places don't have transcranial Dopplers, but it really is the most sensitive method. Anyway, the ultrasound probes are on the temples. She's breathing out through a tube, which is connected on the wall to a manometer. She reaches the arrow has to be at 40 millimeters mercury. And then here's the IV, and you can see blood, 2 cc's of blood in the IV, which goes back and forth to make the foam solution of agitated saline. So these things are and she's sitting upright. So these things are very technique dependent in terms of the sensitivity of the tests. This is the grading scale for transcranial Doppler. Grades 4 and 5 are very large shunts, but we've seen people with PFO strokes who have a grade 3. If it's grade 1 or 2, then it probably is a pinhole PFO. So I use the 20% incidence of PFO in the population because that's grade 3, 4, or 5. Whereas if you use autopsy probe patent, then you get about a 30% incidence of PFO in the population. These are some of the characteristics that increase the likelihood of a PFO being causally related to the stroke. So the neurologists will go through this list, both in terms of anatomy and history, migraine with aura, where the infarct size is. Here's an article showing that these conditions increase the frequency of that the cryptogenic stroke was associated with the PFO, long travel, DVT or pulmonary embolism, Valsalva on onset, migraine, or waking up with their stroke. I actually don't see this that often, but we do. Then I had nothing better to do during COVID, so I got a group together of friends around the world who were interested in PFO, and we tried to change the nomenclature. Instead of calling this cryptogenic stroke, which implies that you don't really know what the cause is, we're now saying that, well, if you exclude everything else and you have a PFO and you have a stroke, these really should be PFO, called PFO Associated Stroke. And the reason for that is that it, as I said, cryptogenic makes it appear that you don't know what the likely etiology is, whereas the term PFO Associated Stroke is more definitive statement for your neurologists, and both the neuro and cardio societies have changed their guidelines, I think, in part by this. It also enables the neurologist to facilitate the workup for PFO if it's an unclear etiology. And it describes the clinical environment, as I described, that is more likely associated with a stroke. And Jeff Saver, our stroke neurologist at UCLA, has done a great deal of work in this in terms of coming up with a grading system for causality of the stroke. And I'll go into this in a minute. And it encourages the use of transesophageal echo as a more sensitive method for identifying PFO. And then if you do come up with a diagnosis of PFO-associated stroke, then you refer that patient for closure. This is Saver's article written with multiple other neurologists on findings from meta-analysis of the 6 clinical trials, 3,700 patients who had PFO and otherwise associated cryptogenic stroke. And in follow-up, there was 121 recurrent strokes. And what they found is that if you identify the risk factors, anatomical risk factors, large shunt by transcranial Doppler or atrial septal aneurysm, or by echo, large shunt, and you include the rope score, which is a measure of the likelihood that they don't have atherosclerotic disease. So the higher the rope score, the less likely you have atherosclerotic disease. So a high rope score and anatomical changes, they call that probable, causally related to the PFO, whereas it's half and half, then it's possible. But if both are negative, a low rope score and not a large shunt or atrial septal aneurysm, then they anatomically, then they define that as unlikely. And they showed that this new scoring system called the Pascal system classification outperforms the rope score in terms of identifying those who are highly likely or possible or unlikely to have their stroke related to PFO. So I believe the neurologists are using this system currently to make that determination. And then these patients should be referred, should be worked up by neurology first, and then only referred later to cardiology to close the PFO. If you look at that Pascal system, those people who got a device had less recurrent stroke than medical therapy, either in the probable or possible group. But in the unlikely group, they actually had more strokes, even in the device group. So these people probably should not be getting a PFO closure. In addition, a late onset atrial fibrillation was more common in the group that was unlikely associated, that their stroke was unlikely associated with the PFO. So I think this is a useful screening method for identifying which patients should be closed. In terms of atrial fibrillation, here's the meta-analysis that we did. This shows that PFO closure is preferable for preventing recurrent stroke, but that there's an increased frequency of atrial fibrillation. It's about 10 to 15%. These devices cause irritation. The cardioform probably causes more irritation than the Amplatzer device, but this is transient. I do treat it because the risk of stroke with atrial fibrillation itself, but it goes away after about 6 weeks when the inflammation from the putting in the device dissipates. So usually starts about 2 weeks after you put the device in, lasts about 6 to 8 weeks. Just as an aside, I think that all strokes, or almost all strokes, in young women taking birth control pills are due to a paradoxical embolism through a PFO. Estrogen itself does not cause arterial cerebral thrombosis, but the estrogen predisposes to venous thrombosis, which then embolizes. The problem is none of the birth control pill studies have ever included a transcranial Doppler or some method for identifying whether patients have PFO. And birth control pills, pregnancy is dangerous in and of itself. So the obstetricians are reluctant not to use birth control pills. But I think in those women who have migraines, we know that there's an increased risk of stroke. And I believe that that's due to that they have the mechanism of PFO, which is why they have their migraines, and then the added addition of the thrombogenicity of estrogen causes their stroke. So let's move on to migraines and PFO. Migraines occur in 12% of the population, more common in women than men. And the connection has been made that you find PFO in about 50% of patients who have migraine with aura. There does not seem to be an increased incidence of PFO if you have migraine without aura, similar to the 20% in controls. And then there have been several studies that show in those patients who have cryptogenic stroke, that about half of them have migraine with aura. And this one study showed 70% suppression of their migraines after you close the PFO to prevent recurrent stroke. So this is a woman that I saw, a 70-year-old woman, had a history of migraines since she was a teenager. As she got older, she developed right hemidiaphragm paralysis of unknown cause, but she then had orthodeoxia. So when she was lying down, her oxygen saturation was 96%. As soon as she got up and walked around, her oxygen saturation dropped down into the 80s, and she was very symptomatic, very short of breath. So here's an angiogram that we did from the inferior vena cava. And so anteriorly is the right heart, and then the left heart, the PFO is up here. This is the PFO, this is the left atrium behind. And you can compare that with after we close the PFO, there's an Amplatzer device. You can see the enormous amount of blood that was flowing to the left atrium through the PFO. So there are some people who have very large shunts and they desaturate and are very symptomatic with this. You can test for this by doing a treadmill stress test. So in your patients who have migraines and they tell you they can't exercise that well, put them on a treadmill and see if they desaturate. Anyway, once we closed the PFO, her hypoxia was relieved and the migraines stopped that she had had all of her life. So the question comes up, what is a migraine? Here's an artist's description of her own scintillating scotoma. This is a physician in the 1800s who drew the fortification spectra. When I went to medical school, I thought that fortification meant that it just got stronger with time, but it's because this pattern of the white bright lights reminded people of the fortifications from the 17th century forts. And it expands over time, usually takes about 20 minutes. And there's been some very elegant work done. This is from Andy Charles at UCLA. There's a condition of familial migraine with hemiplegia. So when these humans get their migraine, they're paralyzed on one side for about 20 minutes, half hour. And so that gene has been isolated. The gene has been inserted into a mouse model. And what you're looking at here is the scalp of a mouse going through a migraine. This is a cortical spreading depolarization. This is faster than it actually goes. It's about 2 to 3 millimeters per a minute, 3 to 5 millimeters per minute anyway. But it's a visual phenomena that you can actually see. In addition, you can see the arterial vasodilation and then constriction. So when I was in medical school, I was taught that migraines were due to vasoconstriction, which decreased blood flow, and that if the vasoconstriction was excessive, you would get a stroke. And that's why you got migraine in people who had stroke. That theory has gone out the window. The amount of vasoconstriction is only about 20%, not enough to cause an infarction. And these people have PFOs as the cause of their stroke in migraine. So the connection, so a migraine is now thought to be a neurovascular dysfunction with allodynia. That means everything's painful, light, touch, sound. The question is what triggers the migraine, and that this may be the connection with PFO. So here's a number of studies around the world that showed that the prevalence of migraine in people who had their PFO closed for other reasons, such as stroke. And about 75% of patients tell us that their migraine is either reduced by 50%, or 10% tell us that the migraine is completely gone once the PFO is closed. So because of that, there have been a couple of migraine clinical trials. This is the premium trial. I was one of the PIs on this. We randomized 230 patients with migraine with or without aura. They had to have a large shunt, transcranial Doppler 4 or 5. And then they were randomized on the tables. So you had to cross the PFO with a guide wire. so that we prove that you had a PFO, because there have been other studies where there's false identification, positive or negative for PFOs. Anyway, so it was a sham procedure with medical therapy versus PFO Closure with medical therapy. The FDA required us to have a primary endpoint as a 50% reduction in migraine attacks, and that endpoint was not met. But the other endpoints were met in terms of frequency of migraine days, which is now the accepted criteria for a positive study. We then pooled our data from Premium with the PRIMA study in Europe and showed that those people had their PFO closed, had a greater reduction in migraine days, migraine attacks, and complete cessation of migraines, 9% in the PFO Closure group, but not in the responder rate, which was the criteria that the FDA required. But this meta-analysis was positive that PFO reduces migraine. And this amount of reduction is similar to what you get with the CGRP inhibitors. So instead of taking a pill for the rest of your life, you get your PFO closed once and that's it. So this is going to be tested in this trial called the RELIEF trial. This is from Bob Summer, who's at Columbia University, and he took about 135 people who had migraines, and he gave them Plavix. And about 60% of the people responded with significant reduction in their migraines. He then, most of them had actually near elimination of their migraines. He then took those people who had responded to thienopyridines and closed their PFO, stopped the drugs. And 96% of them had dramatic reduction in their migraine attacks. So this is going to be tested in what's called the RELIEF trial. So you take people with migraine, give them Plavix. Those people who respond may be the ones who will respond to PFO Closure. So it's going to concentrate the group of possible positive responders. So we're optimistic that this will be a positive study. The theory is that as the blood goes across the PFO, there's shearing forces and the platelets release serotonin, which then travel from the left atrium up to the brain. And we know serotonin is a known trigger of migraines. So that's why we think the Plavix work. But I have 15 patients now who are just waiting for this trial to start, who I've had serious migraines and have responded to Plavix alone. So something that you can do to treat your patients. So I think I talked about this before, but that those people with migraine, that stroke in people with migraine is due to a paradoxical embolism through a PFO and not intense vasospasm, as the previous theories were taught. And that the presence of migraines with aura tells you that it's likely clinically that they have a PFO. So then you look for the PFO. All right, let's move on to some of the other sort of unusual aspects of PFO. We've got a few minutes. PFO and Mountain Sickness. This is perhaps the most interesting trial that I've ever been involved in. So first of all, background information. There was a study in 2006 from Europe. They have these elegant facilities up in the Alps, and they took experienced professional mountain climbers who had high altitude pulmonary edema and 19 who never had high altitude pulmonary edema. They looked for PFO incidence. 70% of these people had a PFO. 16% of these people had a PFO. The oxygen saturation was lower in the group who had a history of HAPE, and pulmonary artery pressure was higher. So the theory is that as you ascend, the oxygen level is content is lower. So you have you get some pulmonary vasoconstriction, which increases the PA pressure, right atrial pressure, increasing shunting. So you get a vicious cycle of more and more shunting, more desaturation, and until ultimately the tissues can't stand the low oxygen content and go into pulmonary edema. Hackett from Colorado did some elegant studies in Nepal on people who hiked up to the Himalayas, hiked up to Mount Everest. 50% of people who ascend rapidly develop acute mountain sickness. You can also fly into Lukla from Kathmandu and then hike, but you don't have the ability to acclimate. So that's where a lot of people get high altitude sickness. So to find out about the truth about PFO and acute mountain sickness, I climbed to the highest place on Earth. I didn't get it all the way to Everest, but this is Amadablan. So I hiked up there, and I spoke to, these are the parents of the Sherpa who did climb Mount Everest. And I asked them, what can we do to study this? And they said, go to Mount Whitney in California. So I climbed Mount Whitney. This is me at 12,000 feet. I like backpacking, so this was a pleasure. And two of us camped out here with our sign, and we got, this is the John Muir Trail, and we got hikers going up or down on Mount Whitney, and then recruited also at Whitney Portal. And then people would fill out a questionnaire. Did they have altitude sickness or not? And they would go to Lone Pine, and my technician was there doing the transcranial Dopplers, which was that picture that I showed previously. And sure enough, there's a higher frequency of PFO in people who have a history of acute mountain sickness versus those who don't. What's interesting is that the incidence of PFO is so high in people even without acute mountain sickness. I'm not quite sure why that is, but these may be the people who climb, who acclimate more by climbing the John Muir Trail before they go down the backside. So there are other causes of hypoxemia associated with PFO. We talked about orthodeoxia platypnea, sleep apnea. There's more hypoxemia at a similar degree of obstruction. Any kind of straining, high altitude, COPD with hypoxemia that's out of proportion to pulmonary disease, those people may have a PFO, and we've closed some PFOs in that situation. You can also have PAVMs and PFO, and that will reduce your oxygen saturation somewhat, especially in the HHT group. We did a study of sleep apnea patients, 100 sleep apnea patients. The incidence of PFO was 42%, whereas in our general population, our controls, the incidence is 20%. This is by transcranial Doppler. So there's a higher frequency in sleep apnea patients. The nadir of sleep apnea of oxygen is no different in the two groups. But the degree of oxygen for the amount of apnea, which is measured by this parameter, the oxygen desaturation index over the apnea-hypopnea index, is different between those two groups. So they get, people with PFO and sleep apnea get more symptomatic at an earlier stage in their obstructive sleep apnea. Then there's been one trial, a small number of patients, where they closed the PFO in patients with obstructive sleep apnea, and the sleep apnea improves because they're getting better oxygenated, so their sleep is better. I want to move on from hypoxemia to another area which is kind of fascinating, rare, but it's does a PFO cause coronary artery spasm and Prince-Metal's angina and possibly Takotsubo disease. So this is a woman I saw about 15 years ago who had was in very good health, had a history of migraines and with the aura since she was 15. So the light goes off, maybe she has a PFO. She had 7-year history of mild intermittent chest pain with stress. She had severe chest pain one day. Her brother's a doctor. Her brother said, go to an emergency room. So she goes to an emergency room. ECG is normal. 15 minutes after she arrives in the ER, she has recurrent chest pain goes into ventricular fibrillation. They shock her, they take her to the cath lab. This is her angiogram. You see this diagonal vessel. They thought this was coronary artery disease. You can't see it too well off here, but there's some distal LAD stenosis as well. They did not give her nitroglycerin. They assumed this was coronary artery disease, and they actually tried to stent this vessel, but they couldn't get a stent down, so they stopped. She came to me a few years later, and we took her back to the cath lab, and I did a transcranial Doppler. She had a grade 5 shunt with Valsalva, so she has a PFO. Repeating the cath lab, no stenosis in the diagonal or this distal LAD. So that proves that it was spasm because it's reversible. We then did intracardiac echo. She has no coronary artery disease as the cause of this stenosis. So because of the PFO, we closed her PFO. We've been following her now for 15 years, and she has no recurrent migraines and no recurrent chest pain. Catherine Dow was involved in this case, and I don't know, she said she couldn't make it to the lecture today, but she's up there working with you folks. Since this time, I've seen both of her sisters who have similar scenarios of chest pain and migraine. We closed the PFO, the migraine and the chest pain have gone away. And I've seen 4 other patients like this as well. So the belief is that just as there may be some chemical that goes across the PFO triggers a migraine, there may be some chemical that goes across insusceptible people that triggers coronary artery spasm. And Paolo Angelini at Texas Heart Institute has demonstrated intense vasospasm in people who have Takotsubo syndrome if you test them within a week of the time that they come in. What we don't know is the frequency of PFO in people with Takotsubo. So that's another clinical trial I would love to do in the future. There's also data that migraine is associated with a higher mortality. This is from the Physicians' Health Study, the Women's Health Study. These are, 25, 30,000 patient studies, and they all show an increased risk of cardiovascular death. So MI and stroke. And the question is if these people have migraine, is it due to a PFO? Is there something bad about the migraine per se? I think it's likely to be the PFO. If you look at autopsy studies, there's a decreasing incidence of PFO that they describe with increasing age. This has always been assumed that the PFOs close with increasing age. But now that we're doing echoes on these people, we've never seen that. I have never seen a PFO close spontaneously. So the alternative hypothesis is as you get older, people die if they have a PFO through the mechanisms that I've described, the stroke, myocardial infarction, arrhythmias from spasm. So if this doesn't completely bore you and you're interested in more about PFO, we've written a book that talks about all these different topics, which you might enjoy looking at. So thank you very much for your attention.
Thanks so much, Dr. Tobis. That was a fantastic talk. So if anyone in the audience has a question, please feel free to raise your hand or let us know in the chat box, or go ahead and unmute yourself to ask. I think Dr. Goldschlager had a question. I'm wondering if she's able to ask the question.
Yes, thank you. And thank you for I learned a lot during this talk, I have to say, and wonderful slides. My question has to do with screening for PFO in defibrillators. I just wonder how much we might be missing, and should we do this? And if so, what's the best method?
So screen for atrial fibrillation in people who have a PFO or had a stroke.
And then defibrillators, how often should we?
The neurologists have looked at this. In people who are over 60, there's a much higher incidence of atrial fibrillation. And the longer you scan somebody, if you put a loop recorder in, the more likely you are to find episodes of atrial fibrillation. But in the younger population, which is the cryptogenic stroke population, the frequency of atrial fibrillation is actually pretty low. We have seen it, and the neurologists have actually sent me only 2 patients who had episodes of atrial fibrillation in young people, but they were unusual episodes. They were exercise-induced atrial fibrillation. And so they thought that their stroke was actually due to a paradoxical embolism, and they wanted those PFOs closed. But by and large, if there's atrial fibrillation, we don't close the PFO.
So we don't screen.
Oh, we screen everybody. Screen everybody who has a cryptogenic stroke gets screened for atrial fibrillation. The question is, how long should you screen for? And so for people less than 60, we usually screen for 1 to 2 weeks with a Zio patch ECG monitor. There are some programs, like in Columbia, they're putting loop recorders in people. But I think that's pretty invasive and not justified in the younger population. In the older population, it would be.
Thank you.
Then Dr. Almaria, you had a question?
Yeah, thank you so much. That was an amazing overview. Thank you for walking us through all the various consequences of PFO. In regards to PFO associated stroke, there's been 2 areas that I have often struggled with myself. One is the patients that have some degree of hypercoagulability. So these are patients that may be destined to lifelong anticoagulation. And so on the one hand, one would think it's not worth closing the PFO. They're going to be anticoagulated anyway. So what are you gaining? On the other hand, however, the argument has been made that some of these patients, given their hypercoagulability and given the likelihood that they may have periods of suboptimal anticoagulation in the future or bleeding events that consequently result in them discontinuing the anticoagulation, that perhaps it actually makes more sense to close those patients. And so, I've been a little bit uncertain of what the best strategy is in those patients. The other one that is very similar is the older patient population that, let's say, is above the age of 65, would not necessarily have been encompassed within any of the randomized clinical trials, but let's say has a PFO that appears to be associated with a stroke. But of course, it becomes much more difficult to attribute that event to the PFO and not to underlying vascular disease.
Correct. So for the first issue of anticoagulation, there's never been a trial of people who have increased thrombogenicity. They've never been included in the clinical trials. They're excluded. But several groups have written about their experience with people who have increased thrombophilia. We've published our data. I just reviewed a paper from Toronto that's going to be coming out on their experience. And basically, everybody says these patients do fine with a device in place. So there's no reason not to treat a PFO, even if you have thrombophilia. Now, what if you're going to treat with anticoagulation, depending on the thrombophilia? So no clinical trial data to support one position or another. But my feeling is those patients are going to have to stop their anticoagulation when they get their knee or hip replaced or some other kind of surgery. And that's the time when, at the highest point of increased risk for a pulmonary embolism or paradoxical embolism. So I actually recommend doing both. Close the PFO, so you've got a permanent closure, and treat them with anticoagulation. And then your other question was atrial fibrillation in
the older patient that has what appears to be a PFO-mediated stroke, right, but above the age of 65.
Right. So I just saw a patient today in clinic, 76 years old, had a cerebral posterior circulation stroke. The PFO emboli, for some reason, have a predilection for the posterior circulation. So bilateral cerebellar strokes. and possibly a retinal artery embolus as well. 76 years old, MRA shows no atherosclerosis in his cerebral vessels or aorta, no atrial fibrillation on ECG testing, and the neurologist sent the patient to me to close. I'm not sure how many people I've closed over age 60 or even over age 70, but there are patients that the neurologists feel this is likely to be PFO related. You'll never know for sure. So it's really its best judgment.
Great, thank you.
And Dr. Gerstenfeld, you had a question as well?
Yeah, thanks for that talk. I guess the question I had as an EP, we spend a lot of our day creating holes between the right and left atrium. And, as an aside, people with a history of migraines, it's not uncommon in the 6 weeks after ablation that their migraines get worse. And we always say, well, it's just the ASD we created. But we know with big sheets like cryoballoon, 10 to 15% of the year have a persistent residual ASD there that we tend to ignore. I mean, do we worry about that? Have you seen any implications longer term after a transeptal residual ASD?
So we've seen this as well, an increased incidence of migraine after transeptal punctures. Most of them close up. You're not really creating an ASD. You're creating a slit. And the slit sort of comes back together most of the time. But as you say, 10% incidence. And some of them do have migraines. There have been some people where the migraines were significant and they went in and closed it with a closure device and the migraines go away. But usually it's not necessary.
Thanks.
But it tells you that right to left shunting is part of the mechanism of inducing or triggering migraine. There's also a higher incidence of migraine in people with congenital heart disease with right to left shunting.
Yeah, I guess the question is, are we exposing people to other potential risks down the road, of stroke spasm, all these other potentials that I can't say I've seen that clinically, but
a stroke from a post-EP study, I think that would be really unlikely for a thrombus to get across. Not impossible, but unlikely.
I have a quick question. You mentioned you don't infrequently see atrial fibrillation after you put in a PFO closure device, and that's usually in the first couple of weeks. So do you treat that more or less like post-op AFib, where there is this possibility that patients, for example, can come off anticoagulation long-term, or do you commit them to anticoagulation indefinitely at that point?
No, I treat just for about 2 months until they're no longer having symptoms. Then we get ECG monitoring, show that they're no longer having atrial flutter. And then I often use amiodarone as well. And so then I stop the amiodarone and wait 2 weeks, and then they're still not having any symptoms. Then I stop the Eliquis, which is my preferred method. But no, I don't use long-term. Other people do. At Mass General, I think they use it for 6 months or a year. I just don't think that's necessary because the atrial fibrillation is just due to the inflammation, and it goes away within a month or two. I should mention the other complications. So there's atrial fibrillation. 1 in 500 people develop excessive scar tissue with these devices, or fracture of the nitinol wires, and they have severe chest pain. And the only way they can relieve that chest pain is to take the device out. And once it's socked in with scar tissue, you can't take it out with a catheter. So they require open heart surgery. With the Amplatzer devices, there's also a nickel allergy, which is 12% of the population. So those people tend to have a greater response or an allergic response to it. So I warn every patient that there is a 0.2% risk of needing open heart surgery. It can be done with robotic surgery now, but it's still open heart surgery. So these devices are not perfect.
Interesting. And then Dr. Ting, you had a question?
Thank you. Make it quick. Thank you so much for the terrific talk. Just want to zoom in on this question again. Looking at the REDUCE trial, looks like that's the one trial that the device has an advantage over antiplatelet meds, right? Correct me. So I don't know if there's going to be a trial comparing to Eliquis 2.5 twice a day or 5 twice a day versus the device coming up, or just mostly your comment on that alternative therapy. Thank you.
So the question is anticoagulation. That was the closed trial, I believe, that had 3 groups, PFO Closure, antiplatelet, and anticoagulation. And they couldn't get enough people in the anticoagulation arm to be statistically meaningful. So they just reported on PFO Closure versus antiplatelet. But there is some argument that those people who have DVT, for example, should be treated with anticoagulation. But there has never been a randomized trial of anticoagulation versus a PFO closure. So we don't really know. On the other hand, anticoagulation has its own risks, bleeding risks. I'm not sure which would be preferable, but no randomized data for it.
That's very helpful. Thank you. It comes down to individual patient decision, looks like. Thank you.
Any other comments or questions we have from the audience?
Hi, Catherine.
I had posted, oh, sorry.
Go ahead.
I had posted a question about Valsalva. When we did a survey of 100 normal volunteers, we found 27% positive PFOs when we used a Valsalva device, which caused the 40 millimeter mercury pressure, but it had a leak in it. So it was a proper Valsalva, not just a Mueller type maneuver. And I was wondering if we did a TEE while someone was using your manometer, rather than just ask them to strain, that we might really improve our TTEs greatly.
Yeah, I doubt it. And I doubt it because the very nature of transesophageal echo, you've got a tube stick down somebody's throat.
No, I meant TTE.
TTE.
Yes.
Yes, I think it might improve it. It would also improve it if you use blood in the syringes during agitated saline when you do your TTE. Are you doing that now?
Yes. Well, when I'm there, I do it.
Okay. Because a lot of places don't use blood and they just use 1 cc of air in saline. And before you inject it, you see these huge bubbles. It scares me to do an agitated saline bubble that way.
Okay.
But so yes, it might help. It might also help if you did the TTE with the patient sitting up.
Mm-hmm.
Because
That's
gravity
a great
will
idea.
get the bubbles to go to the superior aspect of the right atrium.
Yeah.
So these are very technique dependent, but there's still, the reports are something like 50% false negatives.
Well, the lower extremity injections also get the blood flowing against the PFO rather than away from it.
Right. There is a vortex of flow from the superior vena cava down to the tricuspid valve, and from the inferior vena cava up to the PFO, and that's where the eustachian valve comes in. It's directing that blood in the fetus to get the blood across the PFO. So there's this vortex of flow. So when you inject the bubbles from above, they go down.
Right.
And then later you'll see the bubbles in the left atrium, and people say, "Oh no, that's pulmonary." Not pulmonary.
That's right. That's great. Yeah, well, you see the red jet when you're doing a precordial echo in color coming out of the cava and washing up against the atrial septum. Yeah, really enjoyed that talk. Thank you.
Nelson, Walter Henry sends you his regards.
Oh, Walt. Oh, gosh. Send them back immediately. That's great to hear. Thank you so much.
You're welcome.
Awesome. Well, thank you again, Dr. Tobis, for sharing the hour with us and your talk on PFOs. It was really helpful.
I wanted to say hi, Dr. Tobis, John. I've actually known Dr. Tobis for over 20 years, surprisingly. When I was in medical school in New York, I would spend my summers in LA, and he was my research mentor. So it's so nice to see you on video, to get your cards every year. It's really great to, and I'm not sure if he talked about it, but he closed Hailey Bieber's PFO. She talked about it on a really widely watched YouTube video. I think it got 20 million views or more.
Yeah, she did a great job. She's a very smart person and really understood, what we were telling her in terms of the anatomy, physiology, and clinical studies and everything. So yeah, if anybody of you are interested, watch the video that she made.
That's
Great.
awesome. Will do.
All right. Thanks, everybody. Too bad I couldn't come up and visit like the old days. That's a lot of fun to do that, but this was second best. Thank you.